Good morning, ladies and gentlemen. Welcome back to another edition of IMCAS Asia. And today we have an interesting session on the surgical part of hair transplant. And our first speaker is all the way from Brazil, Dr. Hudson. And he's going to talk about long hair FUE, what's possible now and the future. You have 10 minutes, but we also have ample time for the round table, so you can go from 10 to 12 minutes. That's
Okay, thank you.
Okay.
Thank you very much for the invitation. I will talk about long hair FUE, that is a subject that I love. And I'm very glad to be invited here again. So, can someone help me too?
It's not moving. She's coming. Yeah, she's there.
Okay. Yeah, primarily I will talk about the advantages of the long hair FUE surgery. The first thing is the possibility to preview if the density is enough or not. Obviously, the preview of the final result just immediately after the surgery. You can also notice if the extraction don't prejudice the scalp or area. You don't need to shave, and this is very good, especially for women. You can also confirm if the angles, direction, and the designs are good. And it's very important to improve previous deficient hairlines. Like if you do a case before and the density is not so good, is a very good thing to do another procedure with the long hair FUE technique. And also is a good technique for social exposure people, like politics, artists, journalists. I don't have any conflict of interest in this lecture. And about the not so good things about long hair FUE is the main problem is still a very time-consuming surgery. We're improving in this, but nowadays we can't do the same time that we can do in the shaved surgeries. This surgery have a very hard learning curve, and in the start to the beginner's practice, it's common a big number of transections, shaft breakage. So we just recommend extensive case, and I mean extensive case more than 2,000 grafts, just for experienced doctors. If you do this for some time, so you can do more than 2,000 in just one procedure. And what is needed to the practice? Is needed a good device to practice. Nowadays we have like some good machines. The punches also are very important to the surgery. So I prefer to use notches, punches with notches. And you have to observe if you adapt more, what is the punch that you adapt more. We do the surgery, the surgery in organization is very important. Like we start in the lateral, and I work in the right side, and the other surgeon that works with me works with the left side. She's left-handed. And after we start below to up to do these surgeries, it's very important to have adequate harvest instrument, the tweezers, to touch delicate with the follicle, in the follicles. A clean field during the surgery is also very important. In Brazil, we use tranexamic acid intravenously, and this decreases the blood in the field. And also it's important to organize the hairs during the extraction. Normally, we put together like 10 or 50 grafts, like a tree. And this is very important for organization when you start the implantation. And the training before, try to do cases, big cases, is very important also. So in this case, for example, First of all, we can see, we can do the analysis of the recipient area. We do the markings. This patient was 5 to 8 years old, and this is immediately after the surgery. The patient was very satisfied with the result, and the good thing is the patient can't confirm if the density is good, is enough or not. This in the left before, the right after the surgery. We see the improvement of the hairline. This is a girl, 28 years old, and she was very bothered with the temporal area, the entrails in the temporal area. Here a little bit of distraction of the follicles. In the start, we start to do long hair, in the surgery with long hair, but now not just in the maximum 5 to 7 centimeters to do, because otherwise you will do a lot of confusion, a lot of blood and everything. So this is the patient 1 week after the procedure, and she's satisfied with the improvement of the temporal area. I love this surgery. I'm really passionate by the surgery because I really believe that you can improve the results in the future. I know that nowadays the people doesn't like to do this because it's more time consuming, but in the start of the FFE's procedures was the same. So this is a Peruvian patient. He did a surgery before, like 10 or 15 years before, and this is the immediately after result. And you see here the improvement of the area. This woman, she's a politician, a council woman, and she was in the campaign for the elections. And the good thing is that in the middle of the campaign, she did the surgery, and she used this to the empowerment of the women, and it's important to take care of herself and everything. This is a 70 years old patient. We did, in this case, 3,000 grafts. In this first case, we have this patient that is 52 years old, and you see the improvement in the hairline, and he jokes that he now have like 15 years less after the surgery. This other patient, this young man, he had a previous hair transplant surgery before, and we did this second procedure with long hair FUE, and this was a good case because the patient doesn't have telogenous effluvium. So this is just 1.5 months after the procedure. This is also a good case because this patient, for example, he didn't want to appear to show his face, but after he did the surgery, he feels more confident, and he starts to appear more with the face, and was very satisfied. This other patient, he is a dentist, and the important thing is that this patient, for example, he doesn't want to have, anyone to know that he does some procedure. So 3 days after the procedure, he started to work again, and no one knows knew nothing about it. This other case of this patient, he also did surgery like 10 years before, and he searches for the improvement in the hairline and in the crown area. This is one day after the surgery, a little bit of edema. This is immediately after the surgery.
2 minutes left.
And he's also very satisfied. This is an Italian patient. We did, in this case, 4,000 grafts in 2 days. And this is the immediately after. And here you can see what was the hairline before the surgery and after the surgery. This other case, we put more than 4,000 grafts.
2 minutes left.
Okay. And the patient is also very satisfied. And what is possible now? The mega sessions, we just recommend mega sessions if you have experience, because you can lose a lot of follicles if you don't have this experience. For eyebrows, for example, the main indications, I think long hair FUE is so most advantageous than the shaved ones. Also in women. And in the future, with more understanding of the stromal vascular factor use, we can avoid shedding after the preview long hair surgery. Maybe we can work with stem cells treatment associated. We expect new devices and new punches. And also, exosomes and gray hair, you don't know yet if they can't contribute with this, but we have some studies with the stimulation of the melanocytes for gray hair, so we have to wait to see what will happen. Thank you very much.
Okay, we will put all the questions at the end. Okay, so the next speaker is Dr. Desai. He is a very famous plastic surgeon from India. He will talk about the feminine and masculine hairline. What's the difference? Please.
Yes.
Thank you so much, chairpersons, for the kind introduction. And after a very interesting new tech talk, which is hot topic today, long hair transplant by my dear friend Dr. Hudson, I'm going to be talking something basic while my presentation is being uploaded. It's going to be on basically the differences between a female and a male hairline. So, like we already know that hairline is something which frames your face, and anything which frames your face is responsible for the look of the face and responsible for the youthfulness. So hairline is actually the most important telltale sign of a good hair transplant. Nobody is going to probably look at the crown if the hairline is good, and a patient will probably forgive you for poor results in crown to some extent, but not for a bad hairline. So it's very important to understand once my talks, I think there's some technical glitch here, but once my talk starts, it's very important to understand that what are the differences between a male and a female hairline, and of course, what actually constitutes to make a good hairline. So my talk is going to start off with what exactly is a good hairline, followed by the differences. It's going to take time.
Okay, since we are getting that on, if you have any questions for Dr. Hudson, we can take those. It's coming on.
Started? Looks like. Yes, I have no conflict of interest, and is it loading? I
Any questions for Dr. Hudson
okay.
meanwhile?
I think
got
yeah,
it?
finally. Yeah.
Okay,
Okay.
all yours.
Thank you. So finally, so of course, designing a good hairline is a combination of both art and science. Uh, it's not moving. And I have been doing hair transplants for last 25 years. Basically, a good natural hairline, like I said, is crucial for hair restoration. A bald head always draws attention. To take away attention from a bald head, you have to have a good hairline. Use your grafts like a paintbrush. It's very important. This was one statement I heard a very senior surgeon make. So use FUE grafts like a paintbrush, and definitely you have to have a very strong artistic inclination to this. Like starting with the anatomy, you have to know about the mid-frontal point. It starts the central reference point for the hairline, followed by the frontotemporal angles, the temples, the frontal tuft, the definitive zone, the transition zone, the frontal forelock, and of course the temporal peaks. Each of these anatomical landmarks, this is where they all lie, which have to be recognized for a good hairline. So obviously, when you look at this particular picture, the transition zone to the defined zone, maximum density should be at the defined zone. Transition zone should have a see-through effect so that you know that it looks like a very normal and natural hairline rather than it looking very harsh. Okay, and the frontal tuft is where you should have higher density as compared to other points. Um, what other thing? Like, of course, the sex, the male and female, is different, but the profession of the client expectations, the age, the shape of the face, and of course, the number of hairs that we have to implant. If we do not have a good donor and we have to cover a large area, you cannot think of having a very, very dense hairline. You should look at aim at probably moderate density. So that also is important when you're considering. So this is what I was talking about, the transition zone. This is the biggest mistake made by hair transplant surgeon is to make the hairline very, very powerful. No, you have to have a few millimeters of a see-through in the transition zone, which should be of single follicle or maximum double follicle units, a few of them. And just behind the transition zone should be your main dense zone. You have to have macro, which are around 3 to 5 gentle mounds, which are seen from one temple to the other, and multiple micro irregularities, whether they are in form of random clusters, islands of hair, snail tracks, or even if they are triangulations. You have to have it, it's completely irregularly irregular. You cannot follow a certain pattern, otherwise it becomes geometric. So God didn't make our hairlines, they didn't make us similar, nor did they make everybody's hairline symmetrical. So do not aim for symmetry. It has to be extremely irregularly irregular. So that's why these micro irregularities come into place. And here, of course, we are going to start off with the shape, position, the temples, density distribution, direction, angulation, evolution of time, hormonal influence, and surgical considerations. So first is the male hairline is like an M, bell-shaped or triangular as compared to a parabolic U-shaped or a rounded appearance for a female hairline. The contour have to be sharp, angular, well-defined with often a widow's peak. This is desirable, especially in Middle East, sometimes in India, widow's peak, and the lateral ends have to have temporal recession. So the temporofrontal point has to be slightly higher than the mid-frontal point, always. As compared to that, female hairline is more soft, curved. It follows a natural arc above the temples. The temporofrontal points are lower down and blunted or gently curved. Position. Now, if you're talking about the position, it's normally between 7 to 9 centimeters. But if you see what is written below, you follow the rule of thirds, or you take a measurement around 7.5 centimeters approximately from the glabella or the Schinigal point, where the steep angle of the forehead meets the flat angle of the scalp. That's another play, that's another way. And of course, the simplest way is to raise your eyebrows wherever the topmost line is, to keep your hairline above that. Okay, so this is a very simple way how to determine your hairline for a male. For a female, it's much lower. It rarely is at 5, usually at around 6 centimeters. It is more oval, and of course, if you raise it too much, you may masculinize it, especially with the temples. What about your temporal peaks? In males, you have to have it receding. Angle has to be acute, 45 to 60 degrees. It has to be extremely sharp. It can't be rounded, or it will be like a female hairline. The hair is always sparser in the temples and at the receding points. Of course, with higher age, you need to have your temporofrontal points even higher than the midfrontal point for a male. But for a female, it has to be blunt, soft, rounded, wide angle, 90 degrees or more, and maintains a more like a uniform density throughout the hairline, whether it is the front or the temples. Okay, again, density distribution, frontal naturally lower for a male, thinner from front to back, like a forest. Denser you go, the deeper you go, the denser it gets, and there has to be a feathering zone. The definite and the transition zone have to be very, very clearly defined for a male patient, which may not be so much for a female patient. Okay, you don't need to have a very, very powerful transition zone. It is higher, the frontal density is higher at the anterior margin, and a more generalized even distribution. That is what you have to aim at while putting the graphs. Direction in male, more anterior and vertical. Compared to female, it's more lateral and oblique. Hair angle steeper in the front. For female, it's flatter, hugging the scalp. Okay, wherever you are looking, wherever you plan to part it. Natural flow, linear, anterior to posterior. It's more like a radiating or a spiral form for females. What about evolution over time? Men generally have a Norwood classification. We know about this. There are many classifications without going in details, where you see receding at temples, mid-frontal points. You see that even your temples going behind, and you have your vertex developing, typical U shape followed by grade 5, grade 6. This is how the male evolution happens. Female is like a Ludwig pattern. It's more central. Rarely you have a male pattern recession for a woman. It's quite rare, but yes, we do see it, and many times you see the testosterone levels being higher in those cases for women. Then you have to give something to block it. So generally, it's like a Ludwig pattern. So this we are all familiar with. This has been discussed extensively, but this is the pattern what female have. So always, when we look at female pattern, you look at the central density where the part line is. So you see widening of the part line, and sometimes it starts with the temples. Okay, as compared to male, it's completely different. What about your hormonal influence? Of course, testosterone, higher DHT sensitivity, higher levels, lower DHT sensitivity in case of females. Miniaturization is early and progressive. For women, it's slower and less in the frontal zone. You can have diffuse thinning, transgender relevance, masculinizing hormone deepen peaks, feminizing hormones may stabilize the frontal hairline. So actually, topical estrogen has been tried also for male pattern loss in order to stabilize your frontal hairline. Okay, what about your surgical considerations? So, of course, once you understand the basis, the anatomy, the position, then you know what your design goal is. You have to have sharper angles, preserve your masculine peaks and shape, as compared to having softness and roundness for a female, steep angulations, very strongly defined direction, as compared to a generalized feathered appearance for a woman. For men, over-rounding feminizes. For women, making it strong and angular actually masculinizes them. So zone-wise, dense packing has to be done. For female, it's generalized filling, okay, not zone-wise. In male, we divide it into the frontal, the mid, and the posterior zone. But in women, it's generalized filling, which is more important.
2 minutes left.
2 minutes, yes. So perfect direction, angle. This is to be kept in mind when you're looking. So from the front till back, this is the angle that you follow. This is how, I mean, I'm not going in details, but marking the mid-frontal point to the frontal temporal point, I've marked my definite zone behind. Ahead is my transition zone. You can see I've irregularly just marked random drawing. It looks like a sketching as if it's from senior KG or something, but it's not. It's supposed to be irregular, okay? And that's how you'll get your density. Central tuft has to be higher density. Merge with existing hair. Do not have a sharp border posteriorly, okay? Merge it gradually into the bald area, and of course have a very random distribution, okay? Always facing anteriorly for male, right? These are the signs of a good hairline. Well, you may use a pattern like this. I find this very useful. Just take a sketching paper, tracing paper, trace it on it, and just paste it on the hairline. This makes it very easy to draw the hairline. Poor results, pluggy hair, very bad design. I do not need to even talk about this. Extremely bad design. Straight hairline, hair standing up, the angulations are completely off. Many times you have to actually remove these hair. You don't destroy these hair, you remove them and actually use them, okay? So don't, every single follicle has to be respected. Pitting which is seen because not putting at the right depth. So this is also something which gives unnatural results. Cobblestone may appear because of poor healing and extremely large grafts, hole size. Hence, I prefer implanters.
Will you have to wind up?
This is how a very naturally, just winding up, okay? This is how a very natural hairline, this is how you must get, okay? With a slight sleeve through followed by no scalp seen later, okay? This is how a natural hairline looks like. Again, some pictures for a female. You can see the rounding off done. Women, thank you so much. Thank you, chairpersons.
Thank you, Viral, for a wonderful lecture there. Next, we have from Thailand, Dr. Tangrar Sampan, and he's going to talk about treatments of androgenic alopecia in transgender patients.
Okay, good morning, Mr. Chairman, ladies and gentlemen. Today I'm going to talk about the treatments of androgenic alopecia in the transgender patient. This is my conflict of interest. This year, Thailand celebrates marriage equality laws in January. Therefore, I like to present this topic today. Okay, let's start with the terminology. The trans woman or the transgender woman means identify as a woman, but the assigned sex of male at the birth. This is Catherine Jenner. Now, she was the Bruce Jenner Olympic gold medal. Can you believe it? The trans men or the transgender men identify as a man, but the assigned sex of the female at birth. Cisgender means identify sex is the same sex as the assigned sex at the birth. This is my step for the transgender. Usually, I prefer the non-hormonal treatment first, why I will tell you later. Usually, I start with the topical minoxidil and low-level laser therapy because it's really safe. And in the United States, you can buy it both over the counter. You don't need a prescription. The second step is Aldom or the low-dose oral minoxidil, avoid in the cardiovascular patient, and then the hormonal step, okay? And usually we combine the treatment together. And also we have the PRP, exosome, and hair transplantation. We have many hair transplant surgeons today. Okay, I will go to it briefly. First, the topical minoxidil. I don't want to talk much because everyone knows about it. We can use it in men and women. The common side effects include the contact dermatitis and transient hair loss, and it's very safe, it's over the counter in the state, and do not use it in pregnancy. Many years ago, we published the paper to use the minoxidil lotion on the beard area. Then I have the e-patient from the United States. He asked me about the side effect and how to use it. And this 6 months later, you can see. We can use it in the treatment for the beard regrowth too. Dr. Gulakan will talk more about beard regrowth later. The next one is about low-level laser therapy. It's the US FDA cleared in the male AGA many years ago, and it remains a staple of the AGA because of the low risk. Side effects are minor, and usually it's transient, like the headache, dry skin, and temporary onset of teratogen effluvium, but only one study. I use it more than 10 years, and I never seen the teratogen effluvium in my patient. Okay, let's look about the low dose oral minoxidil or Aldom. It's very popular right now. Why? Because the New York Times made a headline a few years ago. So people know about it and ask the doctor about the Aldom. I think everyone should know about this. Originally, it was approved for the severe hypertension with the doses about 10 to 40 milligrams up to 100 milligrams. But there are many serious side effects, including the pericarditis and pericardial effusion. But for the dermatologists, we use the lower dose, mean less than or equal 5 milligrams per day, and it's not approved by the FDA, so in some countries you need the informed consent. Okay, for the efficacy, there are many papers to show its efficacy, so I don't want to talk about it. But what we concern is about the safety. This is the biggest study of the safety of the Aldom. It includes more than 1,000 patients, men and women, in many causes of the hair loss. Okay, they found that about 80% no adverse effects. Only 20% have the adverse effect, and usually it's minor, including the hypertrichosis. Even the systemic adverse effect is, is not dangerous. And for the patient with the adverse effect, most of them can continue the medication after the dose adjustments. Only 1.7% have to withdraw from the treatment. And the reason for the withdrawal include hypertrichosis, fluid retention, but not the serious side effects. This is the timeline of the side effects that I think is very important. Okay. The 1 day tachycardia, 5 day lightheadedness, 20 days about headache, and about 60 days about fluid retention. You have to know about this because you have to ask the patient and expect the side effect so you can more detail in the patient. So when we use it a lot now, there are the rare side effects. There are reports at the same year in 2022 by Dr. Dover from South Africa and Professor Truth, Switzerland at the same year. The first one was the woman 40 years old with the diagnosis of the FFA. She is healthy. Oral minoxidil only about 0.25 milligram, and 3 weeks later, she developed swelling of lower upper extremity and the face, and pericardial effusion. Professor Truth also reported at the same year, a few months later, at the same journal of American Academy of Dermatology case report. The young woman with the diagnosis of the female AGA used the oral minoxidil only 1.25 milligram daily. Within weeks of the treatment, she developed shortness of breath, chest pain, and swelling in red, and they found fluid correction in the pericardial. Even it's the serious side effect, but it's very rare. So right now, many doctors in United States and in EU still using it. Okay, and this is oral minoxidil in my practice. I use the lower dose. Okay, female I use up to 1.25 milligram per day because if you use more than that, the female patient have the hypertrichosis that is not good for them. For the male patient, you can use up to 2.5 or 5 milligram daily. And I usually use it in young, healthy patient and with no underlying disease, avoid the, in women with the hirsutism, and start with the very low dose and titrate dose according to the patient. For best result, I often combine with the other treatment so you can lower the doses of the LDOM. This year, just public article in press, but you can download it. This is a very good review and summary paper from the JAD, the Blue Journal. I recommend this paper. They tell you the table before prescription, during visit, and follow-up visit, what you have to do or tell the patient. And they also have the patient information. You can photocopy this and give it to the patient. Very easy. So the next one is the oral finasteride, is the inhibitor of type 2 inhibitor, 5-alpha reductase. As shown here, it inhibits just only type 2. The side effects include the sexual dysfunction and abnormal ejaculation, and there are some reports of the mood disturbance like the depression, so please be careful, and gynecomastia. And usually it's reversible, but there are some reports that it's reversible. We call it the post-finasteride syndrome. I don't want to talk in detail. But this year, the EME of the EU just confirmed last month, May, confirmed that finasteride linked to the suicidal idea. So please be very careful. And we know that in the transgender patient, they have the higher rate of depression, 70%. So, and higher rate of anxiety. So I try to avoid finasteride, oral finasteride, or the dutasteride in the transgender patient because they have the higher rate of depression and anxiety. This is a small study about the oral finasteride in trans men. They found that it's very useful, and you can treat it like the oral finasteride in the cis men. And some experts recommend to start the oral finasteride treatment 2 to 5 years after hormone therapy because it's the anti-androgen, and not recommend in the breast or ovarian cancer. And don't forget to inform about the teratogenic because you never know what happened in this world. Okay. And for the trans women, there is no study, but we can use it like 1 milligram per day. Because there are many concerns of the oral finasteride, so we can use the topical finasteride, but don't forget that topical finasteride can be absorbed into body and can cause some side effect too. Dutasteride inhibits both type 1 and type 2, so it's stronger than finasteride, but there are more side effects too. So you can use it in patients who don't respond to the finasteride. Spironolactone is the potassium-sparing diuretic, anti-androgen. We use the lower dose for women. We use about 100 milligrams per day, but start with the lower dose. It's approved it's proposed at the first line up for the trans women because of the gynecomastia, so don't use it in the trans men. Side effects, there are many side effects, including menstrual disorder, headache, and breast tenderness. And how about the high potassium? 20 years ago, we had to check the potassium, but right now there are more studies that in the young patient, maybe you need, the young woman, you don't need to check it, okay? I also recommend my patient to avoid food with high potassium too, and some experts check the creatinine every year. And no association between spironolactone and breast cancer, breast or ovarian cancer. My last slide. So usually I start with the non-hormonal, topical minoxidil low-level laser and LDOM, and maybe topical finasteride. And for the spironolactone, you can use that the first line in the trans men. And I combine the treatment, and we have other options like PRP, exosome, and hair transplantation. This is the combined treatment. Okay, I have no time to talk about that. Okay, but combination treatment is the key. Okay. Thank you for your attention.
Thank you so much, Dr. Kanchil. You have to introduce the next.
The next one is my colleague, Dr. Gulakan. She is a field plastic surgeon in Thailand, and she is double board certified in surgery and in the plastic surgery. Dr. Gulakan, please. She will talk about the growing in the transgenders. Very interesting topic.
Thank you very much for your kind introductions. Good morning, everyone. Today I'm going to speak about the beard growing in transgender. I have no conflict of interest. Actually, in present days, that sexual diversity is the common awareness in the public. We have, a young generation can have the right to choose what they want to be, a part of the naturally born gender. So I want to focus only the trans men and trans women. The trans men means that the one that actually generally born with the female gender, but likely to be men. So they're likely to grow more beard. However, for trans women, is the naturally born like male. However, wants to be a figure of women, so they're likely to remove beard. So it is in deficit directions. For the one who likely to grow the beard, the first thing that they can do is to administrate of the testosterone. And testosterone roles in the gender-affirming hormone therapy is often used by trans men and non-binary individuals who identify as masculine. It can lead to a range of physical change, including the masculinization, for example, increased muscle mass, increased body hair growth, and deeper voice, changes in bone structure, and changes in facial structures, and suppression of the feminine traits. For example, stop the menstrual cycles and decrease the breast tissue. And the key point to give the hormone, the testosterone, the practical target for hormonal therapy is to reach the physiologic range of the male hormones, natural male hormones. It is about 300 to 1,000 nanogram per deciliter. And the transgender adolescents usually have stable gender identities and can start to give an growth hormone, gonadotropin releasing hormone analogs to suppress the puberty until they can proceed with hormone therapy as early as the age 16. However, it depends on each country regarding the law of each country, how soon they can use the testosterone or extra hormones to change their sexual identity. The applications of testosterone, common application is 3 forms. The first one is the oral form. It is the oral testosterone undecanoate, or the trade name is Nebido. And you can use it 160 to 240 milligrams a day. The oral testosterone is also easy to use. However, it will be delivered to the liver, so you have to be careful. And sometimes the patient has nausea and vomiting as a side effects. Second form is more popular, is parenteral. You can also use a subcutaneously or intramuscular injection. With the one with subcutaneous injection, it is easier to use. The patient can do it by themselves at home, less painful, and the releasing of the hormone will be gradually and slower. So it is a kind of smoother change in your body. However, the other form is the injection, intramuscular injection. This one can have a quicker or faster effects to change the bodies. So the 2 parenteral forms are also common use. And the other one is the transdermal. A transdermal also are more popular because it will be no pain. You can also apply it to your skin, underarms area, and can absorb into the body, slowly absorb to the body. Some people use it to increase the penis, the gonads. And expected time of the cause of testosterone to change in the body, I want to focus on the hair. The facial and body hair growth, you will see it at least 6 to 12 months after administration of testosterone and up to 5 years. However, scalp hair loss, which is the genetic determination, can also happen when you administer testosterone 6 to 12 months as well and up to 5 years. So after you take testosterone, what we have to concern is the lipid profile. Sometimes the LDL cholesterol can increase, HDL can decrease, and triglyceride may be increased. So we need to check the labs according to this lipid profile for more often after administration of testosterone. And blood pressure can be slightly elevated. Body composition will change. The fat will resolve, however, increase the muscle mass instead. And insulin resistance and diabetes, it's likely unchanged. However, it is a recommendation that we have to close monitor the insulin with the ischemic heart disease, strokes, or the risk of venous thromboembolism, cardiovascular mortality. We need to have a close follow-up. But all of these things, the endocrinologist will take care of the patient. And masculinizing hormone therapy or testosterone replacement, and we would also use it in the gender-affirming hormone therapy. We need to check a follow-up with the lipid metabolism, blood pressure, body and weight composition, insulin, and cardiovascular disease. This is a recommendation to monitor with the patient. However, regarding the hair transplantation and beard transplantation, this is also an option that can growing hairs in the patient who wants to look like masculine without the systemic side effects. And you can grow the beard as preferred shape because genetically, sometimes the beard the patient can have the beard according to the genetic. Sometimes it's just only a small area. For example, upper lips and lower lips, and sometimes with the goatee area. But if they want a full beard, they need something else like a surgery to fulfill their requirement. And the donor side, usually we use the hair from the scalp. And we recommend to wait at least 1 year after the hormone administration. As you can see, the optimal result of the hormones and hair change will be at around 6 to 12 months. And this is the example of the female to male patient. And during his gender reassignment surgery, as a stage procedure, he looking for the beard growing. After he taking testosterone injection for 2 years, he cannot grow the beard. Maybe his genetic is not having hair, having beard. So then now we doing the beard transplantation, transfer from the scalp hair, and it looks good. And this is also the example of another case. And during the stage of sexual reassignment surgery, he grows some beards, but an eyebrow bit thicker with the hormone therapy. However, he need more. He wants to see thicker eyebrow and thicker beard. So we did hair transplantation and plus topical minoxidil over the beard area. And he can grow the beard hair, some of the beard hair and facial hair from minoxidil and hair transplantations. Okay, so I would like to wrap up with the practical points and conclusions. The clinician should discuss the cardiovascular risk with the transgender people before administration of hormonal therapy who have a higher risk of cardiovascular disease or who have the PCOS or diabetes or previous cardiovascular disease should be very careful. And discuss on smoking cessation and healthy lifestyle before using the hormone. And baseline blood pressure, body mass index, lipid profile are recommended in our initial consultations. And we are follow up with the blood pressure and lipid profile after masculinizing hormone therapy. And hair transplantation is another safe option to create a beard for trans men. In trans men who are on testosterone therapy, probably increase the DHT level, leading to a high risk of male pattern hair loss, as Dr. Chuchai said. And there are options to treat with this according to the medication therapies. And in one retrospective study, the mean onset of genetic alopecia trans men is 3.25 years. However, the onset might be earlier for those with the known family history of baldness. Thank you very much for your attention.
May I request all the speakers to join us on the stage for the panel discussion? Dr. Viral and Dr. Rahul Pillai also to please join us.
Okay. You have now? Okay. Any question?
Any questions from the audience?
Or the comment, maybe you have more experience too.
I'd like to ask Dr. Hansen, with long hair, if do you have any tips or tricks to take care after surgery? Because we all know that long hair FUE can be easily pop out and sometimes dislodged after surgery. How you can take care of it, like cleaning, washing?
Thank you. This is one of the main problems that we have in the start of these procedures because we have afraid of lose some hair after cleaning. But I try to clean a lot just immediately after the surgery, and I use oxygenate water, diluted to remove a little bit of the blood, and yeah, this is the
How
thing.
soon? How soon you wash your hair after surgery?
Uh, 2 days after the surgery. In the day of the surgery and 2 days after the surgery, I wash the hair. Because another thing, if you don't wash the hair, you will have a lot of crusts, and so I have afraid that it can prejudice the hairs.
Thank you. Dr. Viral, I have the case, some of the patients, they request a very thick hairline in the front. What do you suggest?
I actually show them some pictures of a very thick hairline, which would have been done elsewhere, and I show them, and I just ask them to actually pull up somebody's like if somebody's normal hairline, and I actually would call some of my staff and show them. So I would say, why don't you look around and then understand this? Because I think that's a demand all patients make practically, unless they start understanding. And I think the moment they understand this, then they would not ask for a very thick hairline. But even if they generally ask for it, then what I would do is I will keep the transition zone a little shorter, little smaller. I won't keep it 1 centimeter, maybe just around 3 millimeters. That also serves the purpose. It actually takes away the harsh look that you get by a very thick hairline.
Dr. Rahul, a question for you. For your hair transplant patients, would you do the non-surgical options before, exhaust those, and then put the patient on the transplant, or straight away put the patient on transplant?
Thank you, doctor. Thanks for asking this question because, see, predominantly I'm a dermatologist. I'm not a plastic surgeon. So my first line of approach is always medical management. And the first thing I always tell all my patients is, see, listen, there is a time if you are balding, you will require hair transplant. The question is, how long are we going to prolong you till you reach that stage? And I've seen in my experience, no matter what you do, with my personal experience, I just got a hair transplant done. So it's like, see, I'm 47 now. I have been applying minoxidil from the age of 29. So I applied it so long. So it took me so long for me to have a hair transplant done. So that is the question is when you're going to eventually do your hair transplant. So always go with coming back to your question, I always go with normal medications like finasteride, minoxidil, even dutasteride. Now the oral minoxidil has come in, although I'm not a big fan of it. I'm a little worried, skeptical about it. At the end, after all the PRP, GFC, everything gets over, is when I suggest a hair transplant. And also one more thing, I always feel you would agree that a treated hair would give you better grafts, while implantation, better success rate than something that has never been treated.
I have something. Usually for the medication, whatever the minoxidil or aldam or whatever, the maximum effect of the topical treatment is about 1 year, more or less. So I tell my patient that about 2 years is the maximum. If you are happy with this result, it's okay. You don't need to go to the hair transplantation. But if 2 years you are not happy, so go to the hair transplantation because that is the maximum that we can do it for you.
Thanks, Suchai. As I've seen your slides, when you give the patients the medication treatment and alongside with some supplements, do you check previously in the blood system if they are demanding like zinc, biotin, vitamin D? Did you check, regularly check for the patient, or you just prescribe a routine?
Okay, thank you very much. Please, I have a lecture tomorrow for this. Okay, anyway, I will reply you briefly. Usually, okay, I will say it both men and women and the transgender. Usually, if it's my case, I don't check it. Okay, I just give I just ask them about what vitamin they are taking. And if, for example, like the vitamin D, if they are taking the multivitamin that contain 1,000 IU, I don't give it. If not, I give it. Okay, but for the severe case, especially in the women with the female pattern hair loss, we know that it may be associated with the iron, many things. So I check the blood level and I give the vitamin according to the blood level. But for the mild or moderate case, I don't check it. I just give it and check the multivitamin of the patient. That's it.
And do you see any difference regarding sexual reassignment patients? The one who wants to be male figure, for example, trans women.
Trans women.
Trans women that they don't do sexual reassignment surgery. I mean, the testis still remains there. I mean, the hormones, they still have some male hormone, but the outside figure transform to women already.
Yep.
Do you find it different when you treat the patients in two categories?
Yes, because if they take the hormone can affect them and it's better than the trans women that don't have the hormone therapy. Because hormone therapy for the trans women, it help the hair already, and patients know about it.
So just treat them like their original gender.
Treat them as
If they don't cut it out. I mean.
just treat them as they are.
Actually, interesting because you asked the question because nutritional therapy is very important because the reactive oxygen species ROS and the free radicals oxygen radicals are basically for many reasons inflammation is considered as one of the biggest causes of aging not only for hair but for skin. So antioxidants in today's world probably is something that we have to consider for every treatment that we are treating aging. Of course, hair loss is a part of the aging. So whether it's for skin, for hair, of course, Amit, you being a dermatologist, do you believe that for skin too, or?
I think it holds true. Supplementation holds true, but I would be a little wary of giving, especially vitamin D, to everybody. I'm a little worried about the toxicity part of vitamin D. You can comment on that?
Yes, this is my interesting topic, and I'm myself taking vitamin D for more than 15 years. And usually vitamin D is very safe. If you give it between 1,000 to 2,000 international units per day and patient don't have the kidney problem, it's okay. So let's do it 1,000. If more than 1,000, you check the blood level and you give it and check it every 3 to 4 months. Like me, right now I'm taking 3,000, but I check it every year right now.
And it's come out normal for the last 3 years.
Usually, there is no standard, but usually they recommend optimal about more than 30 nanogram per ml. But I like my patient to keep the blood level about 40 to 50 nanogram per ml, and I myself is about 50 nanogram. So you can see a good hair.
Dr. Hudson, a question for you.
One last question. Okay.
Yeah, one last question, okay. What is the age for transplant? Like way back, around 10 years back, we remember we were taught that age 30 is a kind of a border. After 30 is when you think of transplant. These days, young guys go in for transplant, even 18. So is there an age for hair transplant?
Yeah, normally we talk about more than 30 years old to do the hair transplant, but there's a patient of mine that previously I did a rhinoplasty for this patient, and the mother of this patient died, and the grandpa of this patient came, and oh, maybe you can do a hair transplant in him because of he was younger, like 24 years old, and I noticed what happens with the confidence for him, because especially between 20 to 35 years old is so important, the image and everything. So sometimes you can do I do some cases in patients less than 30.
Isn't the concept that the hair fall should stabilize by 30 and that's when you put in your hair transplant? So these days you have early people losing hair early. So shouldn't that age be reduced now? The 30 should be now the 20s or 25.
So that's what it's actually a need-based thing. So would you say that you wouldn't give botulinum toxin for somebody who has hypertrophic masseter at the age of 20? No, if they have hypertrophic masseters and maybe they get some pain and bruxism, you would still give toxin. So would you not give a filler for somebody who has a very small chin at the age of 20? It's a structural thing. Similarly with hair transplant, I think it's case-based. So, of course, with newer techniques, and nowadays we have exosomes and so many other regenerative forms, this preservation is become a better if patients are regular with it. So, yes, the age is generally going down. The idea is start early, give them a good, at least a good hairline to start with, because as Arthur mentioned, they lose a lot of confidence, emotionally very disturbing for a young male. And I used to think maybe make them wait. And one of my patients told me, Doc, should I enjoy my life now in my 20s and 30s, or should I think of it in 50s? So that's important. Of course, Rahul is enjoying in 50s, but that's...
Okay, I think we will call this, or rather get this session to an end now. Thank you so much for listening. Thank you, panelists. Thank you, speakers. We had a wonderful session. Thank you so much, all.